And finally, we come to the final session of the day. It may be the last, but not the least. And for presentation, we have none other than Professor Pankaj Pasricha, who was, I am proud to be his understudy and his colleague at All India Institute of Medical Sciences. He's one of the innovators. Before he starts, let me present you a quote that there are only two bequests which a mother can hope to give to their children, which are long lasting. And these bequests include roots and the wings. If Dr. Nageshwar Reddy has given us the roots of gastroenterology in India, it is Dr. Pankaj Pasricha who has taken the wings to take the gastroenterology fraternity to unprecedented heights. Beat the discovery of botulinum toxin or the advent of third space endoscopy, he is the innovator par excellence. With that, I'll hand over the proceedings to Dr. Nageshwar Reddy for taking it over.
Thank you, Anil. I think the sharing, okay. Normally in a conference like this, and we're getting, I think, late in time, one does not introduce the speaker at all. Just say that he's going to speak. But I'll take, with the permission of Anil, I'd like to take 2 or 3 minutes.
Yes, sir. It's certainly needed.
Pankaj, because Pankaj has an outstanding, very unusual career. And for younger gastroenterologists and students, you require to have an icon who can actually look up to. So that we require icons in gastroenterology, and unfortunately not many. But Pankaj is an icon whom we should look up to. And that's the reason I thought I'll take 2 or 3 minutes to introduce that. He, after AIMS, he became the chief of gastro at UTMB. Then, of course, Stanford Institute of Medicine, he was professor of medicine and surgery. And then he finally now is in Johns Hopkins, and look at his positions there. He's the vice chair of medicine for innovation and commercialization. He's the director for neurogastroenterology, and he's a professor of neurosciences in the School of Medicine. I think he's the only gastroenterologist in the world who is also a professor of neurosciences. This is very unique. He's the chair for Center of Gastrointestinal Innovations and Technology of the AGA group, and also is a consistent advisor to FDA on several drug matters. He has several NIH grants, but I think as Anil was telling you earlier, he's not only the botulinum toxin, but the whole third space concept started with Pankaj. In fact, whenever Haro Inovi gives his talk on poems, he starts by acknowledging Pankaj, saying that he was the one who gave him the idea of third space. He holds more than 50 patents, and of course, his innovations are phenomenal. In fact, his main area now, his concentration is on pharmacological therapies for control of glycemia and obesity. In fact, neural control of glycemia is a new concept that is coming up with. And in fact, he's got several awards. I don't want to go into these awards, but he runs, as I said, many NIH programs. He's about 300 papers, several chapters in all the textbooks, Cecil, Hamada, Goodman, Gilman. You go to all the standard textbooks that he's got chapters in that. So I think it's a great privilege this evening to have Pankaj speaking to us. He's, in my opinion, one of the few gastroenterologists who are potential Nobel Prize winners, and to me is a personal hero. Pankaj, thank you very much, and we're eager to listen to what you're going to say.
Thank you, Nagi. What can I say after that? That is very generous. Can you hear me?
Yeah, we can.
I just want to make sure. Very generous, and coming from somebody like you who has a stellar record of achievements in his own right, that is very high praised. So thank you very much. I also want to acknowledge Anil Arora, who has mentioned, was with me at AIMS. He was a year junior to me, and we shared the same hostel building. And I can tell you many stories about him, but maybe some other night. But it is also a source of great pride to watch him achieve what he has, and acquire the kind of national and international reputation. And then, of course, Ajay, who's a dear friend of mine, who's moderating the previous sessions. Always good to see you. But I wanted to dedicate this talk to Dr. Rakesh Tandon, who, as you all know, sadly passed away recently, and was a mentor for many of us, directly or indirectly. He's a scholar and a gentleman. He was there when I was a student at Ames, but throughout my career, I always found him listening to my talks at DDW or some other forum, and he would come up to me and congratulate me and give me encouragement. So I think I'll miss him today. I'll miss his presence today after this talk, but I hope you'll join me in wishing his soul and his family all the peace and joy. Thank you. So Anil had originally asked me to talk about, I guess, the future of endoscopy and innovations that may be emerging. As if anything, the COVID crisis has taught us that it's almost impossible to predict 3 months from now, let alone a few years from now. Since that is the case, I thought I would rather spend my time not talking so much about specific ways that the future will change, but rather how I learned about the ability to come up with innovative ideas and perhaps, and I say this with all modesty, change the future. So it's not so much about what the specific embodiments are, it's really the process by which you think of those embodiments. So if you'll indulge me, I'll spend a few minutes talking to you about that. So let me go to slideshow. Can you see the full slide, or is it on a slide?
We can see the full slide.
Okay, good. So what are the principles of effective innovation and how to integrate them in your practice is what I'll spend the first half of this talk about. As we are very familiar and as we have seen in some of the talks today, the current paradigm, and this applies to not just GI innovation, but medical innovation in general, we start with a solution, as an example from the previous talk, and Vivek gave a wonderful talk, and I congratulate him on it, but we start with the solution. Let's start with octreotide as an example, or start with a pancreatic stent. And let's figure out now what the problem is. So if the problem is post-ERCP pancreatitis, let's try to put it in place and see if it works. And we do that. Sometimes it works, sometimes it doesn't. We get into, some clinical trials, validation, but then we say, we're ready to go to market. And when we go to market, we realize that many of the steps that we needed to take were missing in this formulation. And therefore, we've not only spent a lot of time and resources, but we may never be successful. This is a lesson I learned very, very early on. And I want to tell you about some of the steps you can take to avoid that. But the key to innovation is not the solution. This is a very important concept, and I'll keep trying to emphasize this. The key to innovation is finding the real need, filtering it, refining it. And if you don't do that, then any solution that you bring forth will be unlikely to succeed. I'll give you some examples of that. And again, just before I get into that, need finding does not simply mean asking questions, asking your colleagues, asking your patients, asking your collaborators in the industry. Henry Ford's famous quote, if I'd listened to my customers, I'd have given them a faster horse, because at that time, that was what people were doing, just riding around on horses. Finding a need is really about an unbiased approach to solving the problem. And if you don't go through the very rigorous intellectual exercise about formulating the need statement, then your innovation may not succeed. This is like finding the genetic code, as Tom Crummell, my colleague at Stanford, often says. And I'll give you an example. You can come up with a need statement. 30 years ago, people said, I want a better method to do coronary artery bypass grafting. That need statement is, as far as I'm concerned, pretty useless. It doesn't give you a way forward. It doesn't tell you what the right solution should be. A better need statement is a better method to revascularize the heart. And if you came up with that need statement, as Andreas Gunsig did, he came up with the concept of balloon angioplasty, first in the peripheral arteries, and then of course it was applied to the coronaries. So he didn't want to sort of say, let me figure out a less invasive way to do the exact same thing, which was bypass. But what he wanted to do was get to the heart of the problem, which is heart of the problem is ischemia. How do I revascularize it? Having done that, he opened his mind up to all kinds of possible solutions.
Pankaj, sorry to interrupt. Can you do a slideshow so that the whole slide is seen? We're seeing part
Yeah,
of
that's
it.
what I was asking. I don't.
Yeah. Can you do a slideshow?
Is that better?
Yeah, now it's better. Now.
Thank you, sir.
Okay. So what I was saying was the need statement here was how to revascularize, not how to do better bypass. We fall into that trap a lot. I'll give you another example. When I was at Stanford, so we ran this biodesign program at Stanford, very talented team of trainees as well as people from industry. And many of you have gone through this exercise of doing a lumbar puncture. And it was clear that there were problems with leakage happening very, very frequently. And if you did a survey and you just talked to doctors who did this, they say, well, there's a need for a better method to perform lumbar puncture. Again, this need statement is pretty useless. Yes, that's obvious, but it doesn't really get to where the right solution is. So this team of trainees in the biodesign program went through this exercise, filtered the need statement, refined it, and came up with the need is a better way to control access to the epidural space. Now, with that need clearly stated, they came up with the right solution. And it is the simplest of all solutions. It was simply a screwdriver instead of a straight needle. Because the engineers on that team said, look, you want to have control access, we can do this with a screwdriver. Because with each turn of the screw, we advance incrementally as opposed to try to push a needle through. And so they actually came up with this design for a screwdriver bevel for the epidural space, and they were able to reduce the complications. And now this is a commercially available device. It's called Epiphany. Other examples, from sort of our own work here at Hopkins, you know the story about type 2 diabetes, medicine, surgery, gastric bypass is the big solution now for type 2 diabetes. And what does it do? It bypasses a critical part of the duodenum. So you could come up with a need statement that says, I want to do gastric bypass better, laparoscopically, for instance, which is now being done, or I want to do it endoscopically, some way to create an anastomosis. But really, the need statement was, the correct need statement was, how to better exclude the duodenum from coming in contact with the luminal contents. And once you identified that need, then you eliminated the need for surgery or endoscopy or anything like that. You just said, give me anything, the easiest, simplest method to exclude the duodenum from luminal contents. And this was the genesis, again, this was the biodesign team at our Hopkins Center. And some of you might know Ashish Nimgamkar, who was my trainee at Stanford and joined me at Hopkins, and now is the CEO for this company called Glycin. And what is the idea? Basically, it was about giving an oral mucoadhesive that stuck to the duodenum at the right pH. And once it did it, it basically prevented contact from duodenal contents, or from duodenal contents making contact with the duodenal mucosa. And you can see in diabetic rodents, just simple gavage of this material had a highly significant effect on postprandial hyperglycemia. And with that, we were able to raise this last year or this year, early this year, $20.5 million to advance this now to human trials, which will begin next year in Australia. But it started with that refinement of the need statement. We would never have come up with a solution if we had simply said, I just want to do what gastric bypass surgery does, but maybe less invasively. So that is the biggest lesson I've learned, but there are other lessons I've learned, which I'll briefly talk to you about. First of all, innovation is not a black box. Okay, many people think, oh, you either have it or you don't have it, and I can never learn it. Actually, innovation can be taught and it can be learned. This is an article we published in Gastroenterology several years ago about the whole biodesign learning process. It's very elaborate, it's very formal. It's like taking a course in organic chemistry. It's structured. There are steps, there are methods, and they're scientific. And so you can teach people innovation and you can learn innovation. And again, the top two boxes here are all about the needs. And then there are many other things which I don't have time to go into, but I'll encourage you to read this article. And if you want, the book, which is written by the Stanford biodesign people. The other lesson I've learned, and this is obvious today when Nagi was talking about bile stents and Vivek was talking about PRCT. You know, as a doctor, no one has more passion for patients than you as a physician. And the welfare of your patient is paramount to you. But the welfare of the patient is not just about giving them what's available today, but coming up with solutions that are not available today. And that's really part of the commitment you make to the patient as a doctor. And this is a very important driving and motivating force, at least for me. I'll give you an example. I mean, you know, I started off as a therapeutic endoscopist. I was the first therapeutic endoscopist to be trained at Hopkins. And I thought I'd spend my whole career doing ERCPs and invasive procedures. But because of the work I did with botulinum toxin, people assumed I was a motility expert, which at that time I was not. And they started sending me patients like this, 35-year-old nurse with diabetic gastroparesis, nausea 24 hours a day, vomiting. And there were no solutions. There were no solutions for her. And this is what then motivated me to start going into the biotech side, into the pharma world, because no company at that time was interested in coming up with a solution for gastroparesis. As I like to say in this cartoon, there was no cure. There was not even a race for the cure. So when I was at Stanford and I got tired of seeing these patients in my clinic without offering them a solution, I said, okay, pharma's not going to do it. What can I do? Surely there must be something that I can at least try, even if I don't succeed, because if I don't try, then I'll not have lived up to my commitment to this patient. So I went on this search for a chemical database. You know, I spent 6 months searching for a drug that worked like metoclopramide, did not cross the blood-brain barrier, and unlike domperidone, did not have any heart effects, cardiac side effects. I found a lead compound, which is actually available in France, of all places, and was being used in France for 50 years, but had never been tested before. We were able to get it. We were able to actually file a patent on it, which was a miracle on its own, and got that patent approved. We formed a company, spent 5 years, 5 long years, trying to raise money. Nobody was interested. And then finally, 3 years ago, we raised $45 million. And this week, actually, I'm pleased to say that our phase 2 trial has recruited its first patient. So we don't know it'll work. It looks promising, but it's not easy. It's been 10 years of that journey. And the only reason that I stayed in that journey was because, like so many of you and all of you, I had that passion to do something different for my patients. The other thing that starting thinking about entrepreneurship or trying to commercialize actually forces you to be very rigorous in your thinking. And I found that actually reinforces the way I think as a scientist when I'm applying for an NIH grant is very similar to when I start putting an idea in front of investors. You know, in the NIH review criteria, some of you are familiar with this. On the left side, we are judged by these 5 criteria: significance, innovation, approach with investigators, what the environment is. And these are parallels when you start going to investors with an idea. The significance is the unmet need, the market size. Innovation, of course, is the IP. The approach is the preliminary data, but also very importantly, Have you checked out the regulatory status? How easy is it to get FDA approval or the equivalent in India? Who's going to pay for it? Is there a reimbursement strategy that actually you can employ? And of course, the scientific business teaching, innovation. The other lesson I learned is that clinical care, research, and entrepreneurship actually feed on each other. These are not separate silos. If you are doing active research, it doesn't matter, clinical, translation, bench, your ideas deserve to get in front of the patients. And the only way they can get in front of the patients is if you know how to take them to the market, because otherwise you're going to sell them out of your garage and probably go to jail. So as you mentioned, one of the things I learned as a fellow was pneumatic dilatation for achalasia. But, very soon, and I'll tell you why, I realized that we had to start taking more risk if we are going to disrupt how to take care of patients with achalasia. I had my first perforation as a fellow in 1989. And I said, there must be a better way to do it. And you know the story. We said, let me inject botulinum toxin, first did it in pigs, and then did it in a human for the first time. My chief of the GI division at that time, Mark Donowitz, took me aside before the procedure and said, I heard you're going to inject botulinum toxin in a human. I just want you to understand that the division is not going to cover you, and I hope you have a good lawyer. So risk-taking is part of the entrepreneurship. Anyway, obviously botulinum toxin was useful in some patients, but for the majority of patients, it wasn't really a solution. And that's where we led to, okay, the myotomy concept, right? Myotomy was the best way to take care of achalasia, but was there a better way to reduce muscle competence? That was the unmet need. And that was the need statement. And that's what led to POEM. But it's still not a cure. POEM is still palliative. And therefore, from my basic science work with neural stem cells in the gut, which we identified 3 years ago and published in this paper in PNAS, we said we should now be thinking about transplanting stem cells into the esophagus. And this year, in February, we did our first human case of stem cell transplantation in the esophagus. So far, so good. No adverse effects. We're going to follow up, see whether he responds, what the objective improvement is. But it was a risk. But it was a risk, a calculated risk, and it is an extension of the finding the right unmet need. The unmet need here was how to restore neural function in achalasia and thereby cure it. And just for the last few minutes, this whole stem cell idea may seem too complicated for many of us who are not into enteric neurobiology, but it doesn't have to be complicated. The best ideas are often the simplest. This is Halstead, founder of American surgery, first chair of surgery at Johns Hopkins, along with Osler in medicine. He had a problem that his head nurse in the OR, who was actually his mistress on the side, by the way, a side story of Halstead, he was a heroin and cocaine addict. I don't know if you know that. And he remained that throughout his life, because at that time, a lot of these people were experimenting with cocaine. And they used to wash their hands with carbolic acid and disinfectants, and his nurse started having skin rashes on her hands. And he came up, he asked the Goodyear company, which is a rubber company, to make a glove for her. And that was actually the original glove that they made for her. And she started using that, and then they started using that, the surgeons started using that, and that's really how gloves were introduced for modern American surgery. Now, shouldn't give all the credit to Halstead, because the Europeans had already started thinking about using gloves, and some of them were using gloves, but American surgeons had resisted it. But this particular problem of reducing the skin irritation led gloves to be widely adopted for surgery. And why do I bring that example up? I bring that example up because many of you who do ERCP are very familiar with sort of, people talked about the biggest problem in gastroenterology from a medical legal perspective being post-ERCP pancreatitis. Well, this is a huge problem too. And this is the incidence of scope contamination. You're all familiar with that, so I won't go into that. I just want to set that as a background for what the unmet need was. The unmet need was not, in my mind, not how to disinfect the scope better, whether it was ultraviolet or irradiation or whatever chemicals you want to use. The unmet need was how to prevent infection in the first place, how to prevent contamination in the first place. And that's where the glove analogy came in. So basically, we wanted to prevent two-way contamination, just like the glove prevents contamination between the patient-surgeon and the surgeon-patient. We wanted to have a solution for the duodenoscope. And we came up literally with a glove for the scope. I remember that we were at DDW 4 years ago, and this was the hot topic. And I met with my collaborator in industry. And I said, Scott Miller is his name. I said, let's stop doing what we're doing and come up with a solution. And this was Scope Seal. And within 24 months, we really had close to a finished package. And now it's FDA approved, and I'll talk to you about this. But these are the problem with the glove for a duodenoscope was, of course, the optics. Could we come up with something that was completely sealing, but also preserve the optics? And bottom two are images with and without the scope seal, and you can't really tell the difference. So the technology summary, it is like a skin that goes on the distal end of the ERCP scope. This has been published now, so I don't need to go into details. Please refer to the article in GIE. But this is what the scope looks like with the seal on. You can barely see it. And you deliver it with a very simple mechanism. We've tested it in dye immersion tests. It prevents even nano-sized particles from getting into the scope. We tested its ability to protect against microbes that are introduced from the outside. Again, I don't want to spend a lot of time on the details, but we contaminated the scope with the scope seal on, and basically you have 100% contaminations without the scope seal and 0% contamination with the scope seal. This is from the patient to the duodenoscope. But if you have a duodenoscope that's already potentially infected and it's hard to get rid of, this also prevents contamination from inside out. So if you have a microbial challenge inside the scope, especially around the elevator with the scope seal on, there is no leakage of that bacteria into a solution that you immerse it into. And then the optics are just as good. And this is some sophisticated tests we did that involve MTF, which is a standard way to look at the optics and the resolution. And these are just visual examples in an animal with and without the scope seal that show the optics are very nicely preserved. And it allows us to work with all of these instruments shown here without any difficulty. And of course, there are other solutions. And I'm saying this not to tout this technology, but trying to reinforce the point of finding the right unmet need. You can say the right unmet need is, better disinfection, but that has its problems as shown here. You can say the right unmet need is, well, just take the distal end out. That had its problems. And then, of course, you can have a completely disposable duodenoscope, as some companies are trying to do. And yes, you can eliminate the risk, but the costs can be prohibitive. And the quality imaging and others are still issues. But if you had the right unmet need, you would come up with what we think is the best-in-class solution. And it wasn't because we didn't think of those other things, but we had identified the unmet need. So in conclusion, lessons I've learned, no one has more passion for patients than you, so don't think somebody else will come up with the innovation. If you have an idea, take it all the way. Entrepreneurship teaches you to be rigorous in your thinking, Your clinical care and research can feed on your innovation. You need to be able to take risk, but you need to also be able to contain it. The best ideas can be the simplest. And entrepreneurship is not a way to make money for physicians. Entrepreneurship is a way to take your ideas to patients, which means taking them to the market. So if you really want to take your ideas to the patients, you have to learn how to be an entrepreneur. And again, the key is to correctly define the unmet need. The unmet need paradigm is similar to the nail and the hammer paradigm. The traditional way of innovation in medicine is, I have a hammer. I just came up with a device. I just came up with a drug. Now I want to find where I can use it. So you go around looking for the nail. The right way to figure out the unmet need is the patient-centric way. Identify the nail first. This is the unmet need. And you know what? You'll be surprised. There are 20 different kinds of hammers that you can use if you know where the nail is and what the nail is. And finally, I don't want to dismiss this. You just need one more thing. Okay, I'll give you a little quiz before I give you the answer. Name the most innovative automobile company that you can think of. Everybody says Tesla?
Yeah.
I assume. Okay.
Yes.
Okay, I'll give you a hint. Clean energy, of course, Tesla. All right. In 1912, more than 100 years ago, the Detroit Electric Company produced this car that could go up to 60 miles an hour for up to 40 miles on battery. All right? And it was very popular. So what happened? What happened was the discovery of gasoline a few years later and made it very, very cheap, and people switched to gasoline, and this company died. Although 100 years ago, it was clean energy, efficient, non-polluting. Think of how the world would have changed if we had stuck to this kind of automobile. So what else you need? You need luck. Luck needs to be on its side, and I have no way of telling you how to get that. Maybe you can do a mantra or something, but that's up to you. So thank you very much.
Thank you, Pankaj, for that outstanding lecture. In fact, lecture itself was very innovative for all of us. So, of course, we don't have too much time for panel discussion, but we didn't want it to be a very structured panel discussion because this is a topic that requires a lot of free thinking and innovation. So we left it very free. I have a very distinguished panel here. I don't know how many of them are there. Dr. Sneha John, Dr. Manish Bhatnagar, Dr. Banka, Dr. G.N. Ramesh, and Dr. Deepak Chowdhury. I think we'll start with Dr. Deepak Chowdhury. His thoughts on this. I think we've had a fantastic talk by Jay. We all know that when we watch and listen to him speak, we all think maybe we can become innovators, but I don't think it's as simple as that. I think it's a different mindset that's required. Deepak?
Thank you for having me on the panel, and it was a wonderful lecture, Pankaj, and innovative and very motivating. Maybe we all physicians start thinking like entrepreneurs, and maybe we'll come up with something in future. I have a question for you. You have done so much work with innovation. Where is artificial intelligence coming into GI and other related medical fields in near future?
Jay, you want to take it up? Yeah.
You want me to answer that?
Yeah.
Yeah, Deepak, thank you. Of course, artificial intelligence is here, not just for endoscopy, it's here for every aspect of our life. So artificial intelligence is one of those pervasive, universal technologies that will transform everything we do, whether it's in medicine or even, it's already doing that, right? Your Google searches are all based on artificial intelligence. So every aspect of your life is now going to be algorithmized in some way and subject to machine learning and artificial intelligence, which are related concepts. So I'm not surprised that we've seen in the last year itself, but in the last 3-4 years, this steady drumbeat of going to artificial intelligence and machine learning for solving some complicated problems. We produce huge amounts of data, even with a simple endoscopy, 99% of which the human brain is incapable of capturing or analyzing. That data is going waste, right? And so that is the power of artificial intelligence, is basically, and that's what it, in its truest way, that's what artificial intelligence should do. Come up with an intelligence that's beyond the human, not necessarily to replace it, but to inform it. So I'm as much an expert in artificial intelligence as a layperson in some ways, but I've kept abreast with the developments, and I think, yes, we will see improvements in how we analyze information for sure, but it's up to us then to utilize that advantage for true unmet needs, right? And that's the difference. That's just another technology. And then if you go back to that analogy of the hammer and the nail, then you're going to be looking for the nail for artificial intelligence for everything. You need to find the right unmet need and say, this is something that needs better data processing, information, analysis that no human being can do on their own, and will solve a critical unmet need. Otherwise, you can apply artificial intelligence to everything we do. Sorry, I don't want to belabor that. Sorry, but very nice question. Thank you, Deepak.
Yeah, that's a very nice point, that one should look at an unmet need. And I think already in endoscopy, we have an unmet need of a less qualified endoscopist trying to make a complex diagnosis, and AI now coming into endocytoscopy and so on to help us. I think one of the innovations that occurred in this COVID period is this telemedicine. So we have Dr. Sneha John right from Australia talking to us. So we'll take her comments now, Dr. Sneha.
Thank you, Professor Reddy, and it's been fantastic to listen to Professor Pasricha.
I'm sorry we got up so late.
I know, it's actually 2 o'clock in the morning for me.
Wow.
So Professor Arora has a very persuasive manner, so I couldn't say no when he asked
Well, his persuasive manner is to send you a message every 5 minutes. That's what he's been doing since last night to me.
But we are early risers in Australia, so I don't mind. And this is such an exciting topic. So I was very moved by the fact that you said innovation can be taught. And I particularly enjoyed the fact that you said no one has more passion for our patients than we do. And to me, those were the 2 points I'd take away. So in answer to your question, Professor Reddy, in terms of showing that passion with telemedicine, we've recently done a survey of a lot of trainees from, including India, both Europe and Asia Pacific, and education and maybe being out of touch with what is happening in their field was one of the major concerns raised by a lot of trainees all around the world during COVID. So in answer to that particular query about telemedicine, yes, it's an innovative way of educating. And perhaps there was a need for that even before COVID. And perhaps there are good things we can learn from this. If I may say something about the artificial intelligence area that you talked about, because my focus is in upper and lower GI endoscopy. One of my really good friends has this very nice way of putting it and making this an analogy with driving, because they're in Germany and cars are everything. And they say, look, if you learned on a manual, you can drive any car. If you only ever learned on technology and an automatic, perhaps it's very difficult in certain situations, and that the cognitive ability of the driver is not taken away by any technology in the car. So perhaps AI for me, when I think about how we might put this into practice, particularly for our next generation, I believe as teachers, maybe, yes, we should teach them innovation, but we should start also by teaching them the basics very well so that they know how to use the innovation, look at the unmet need, find the unmet need. And in my world, this is still how to help the whole world of endoscopy, not just elite academic centers, improve detection of early GI neoplasia. And if we thought about AI as a fairly expensive technology, maybe in the first half. There's still a lot of unmet needs we can still cover without AI by helping colleagues in all parts of the world achieve those.
That's an excellent point you made about the artificial intelligence, that the danger, and lots of dangers people talk about, but one of the dangers is it creates another barrier between the physician and the tools. So, the cars, for instance, when I was in India, I had this Fiat car, Premier Padmini or whatever. I knew exactly how to fix it if anything went wrong. Pop open the hood, change the spark plug, carburetor. I knew exactly what everything was because it was simple. Today, I would not dream of opening the hood without going to a garage first, right? Because it's just too complicated. And there's a danger. Even that happens with patients, with our patients, and with the technologies that we use for our patients for that barrier to come in. The other thing about the telemedicine thing, we've been practicing telemedicine now for the last 6 months, as everybody else has. And there are unmet needs there, not just in terms of, the education and all that. There is a missing factor, right? The contact, the ability to form the bond, especially with new patients. With follow-up patients, it's easier.
Yeah.
And this is an example of, the opposite. Maybe there's technology that can help with that and make that experience more real than it is today. So that's another example of what the unmet need is. If you identify the unmet need, it's not just having better connectivity or your better background or whatever Zoom embellishment you want. It's really, how do we restore that relationship?
Yeah.
And that may be I'm not saying it is, but it's room for technology. And I don't want to go back to that previous talk on with Vivek, but I was struck by one thing, and I wanted to talk to Ajay if I could make a comment. Post-ERCP pancreatitis was recognized by the panel as a huge problem and by gastroenterologists, and Ajay said it is recognized by the Board of India and the ethics. I want to ask you, who in the ERCP community who recognizes this as such a huge problem has actually done research on what the biological basis of post-ERCP pancreatitis is? Nobody. Why not? And I don't mean this as a criticism. I'm saying, think about the unmet need. The unmet need only will happen if you think about it. It's not simply just trying one drug after the other or one stent after the other. Let's first understand what is the biological basis of post-ERCP pancreatitis. And there are clues. We have published papers on some of those clues. I'm not saying they're true, but this community who is engaged and has a passion for preventing post-ERCP pancreatitis should invest in that kind of research as well. In the kind of research that actually exposes what the true unmet need is. That's the point of it. Sorry, I don't want to go over my time.
Jay, that was a fantastic talk. Yeah, sorry, if I may.
Go ahead, please.
15, 20, this is exactly the line of thinking. My question 20 years ago was, when a surgeon does a scalpel incision and a Whipple, patient doesn't get pancreatitis. Here we put a little wire and patient gets pancreatitis. Nobody has ever been able to answer that question, is that Bovie-induced surgical trauma doesn't create any pancreatitis.
So,
and,
Vivek, I'll send you a paper. I'll send you a paper, and maybe you can do a trial with collaborators in India.
Good question.
Yeah.
Thank you.
Thank you.
Just
so
GI is coming with a full issue on AI, just as a FYI, very soon. It was supposed to be September, but it is deferred for COVID. And the other thing with AI is a perfect example of hammer and nail. AI is a technology finding a use. And I think more than endoscopic applications, I think systems applications, such as telemedicine, such as improving our processes, that's where it'll probably find the maximum value, not in recognizing polyps.
Thank you, Vivek. I think we have another leader in gastroenterology in India from Mumbai, Dr. Banka, who's actually a lot of innovations, Dr. Banka, in practice. He's an innovator in practice. So maybe you can give us actually this question which Pankaj brought about of how you can improve your practice with telemedicine.
Wow.
Any suggestions, ideas on that?
Nagi, it's so, I remember of an article. Can you hear me? Is it possible?
Yeah, we can hear you.
Okay. So, listening to Jai reminded me of an article written by John Dewitt and Van Dam during the diamond anniversary of gastroenterology 2 years ago, 2018. And he has written an article about innovations in endoscopy. And when I was listening to Jai, everything fitted into that. He summarized the entire thing as the innovation expanding so rapidly and expectations must be tempered as research is performed to determine safety, outcomes, patient preferences, quality of life, training required, and cost of the procedures. I think, Jay, everything fitted in so well today. I enjoyed your talk. Thank you so much. Thank you.
Thank you, Pankaj. We also have Manish Bhatnagar, who's, of course, also a leader in the field from western part of India. And Manish, your comments on this?
Sir, good evening. It was indeed a pleasure to listen to Dr. Pasricha after 3 years. He visited Ahmedabad and he talked on innovation 3 years back. Obviously, this is a more updated talk Dr. Pasricha gave. I think, sir, there's nothing much to be added to what all the luminaries have said. I think we have two major innovators I know of. In India, it's you, and abroad, it's Dr. Pasricha. We know the innovations which are going to be technologically driven in terms of better optics, better instruments, better techniques, new technologies, which will definitely come. My only fear is that artificial intelligence may blindside us if we get too focused on AI, which may happen. There are some sci-fi movies which have explored this option, which is obviously out of the mandate of this particular discussion. But I think AI can never be a substitute for native intelligence. I think we'll still need to go back to the basics. And like you rightly mentioned for telemedicine, that touchy-feely thing to establish the rapport with the patient can never be substituted by a screen. Like Dr. Pasricha said, maybe there needs to be a need statement which takes care of this thing, and we could look at the innovation. Not everybody can be a teacher, an innovator, a scientist, a motivator, and also an entrepreneur like you and Dr. Pasricha. But I think for lesser mortals like us, I think new innovations are obviously a blessing, but we shouldn't get too fixated on the technological prowess part of it.
Thank you, Manish. On that humbling note, I think we should end this very important session. This was a really innovative session with so many, the great talk that Pankaj gave, and then, of course, the nice comments we had from the wisdom pearls that we had from many of our panelists. I'd like to thank you very much and thank Anil for giving us this opportunity. And even I can see late part of the night, so many people are hooked on watching this program. Thank you, Anil.
Thank you.
Thank you, Dr. Nagi. It was a pleasure to listen to Dr. Pankaj Pasricha. Pankaj, if I have to summarize your talk in one sentence, if you cannot become the Nageshwar Reddy, at least I can become the Pankaj Pasricha tomorrow, because you said it can be taught, which I thought I can never learn. Thank you for telling us that entrepreneurship can be learned. So you can become Pankaj Pasricha one day if you keep
Absolutely.
trying.
Absolutely.
But we can never be Nageshwar Reddy because it's so good above all of us.
Nobody can be Nagi. We agree on that.
Thank you so much for telling that it can be taught. I thought it was inborn, it can never be learned. With that, we come to the end of the present session. I am thankful to all the panelists who have taken their time off their busy schedule to enlighten us on the innovation in endoscopy. And I am again thankful to Pankaj for answering a lot of questions which I could not get answered during our stay in the hostel at All India Institute of Medical Sciences. With that, we end up this session, and may I request, as is the customary program, may I request one of our colleagues from Gangaram Hospital, Dr. Mandhir, to give us in 5 minutes the summary of the day, so which is a recap of those who have joined late and may have missed one of the sessions. Dr. Mandhir, please.
Thank you, Anil. We had wonderful sessions tonight. We had total 5 sessions. The first was on idiopathic recurrent acute pancreatitis, which was delivered by Dr. Pramod Gar. I'll just summarize what he said. It can be defined as 2 or more attacks 3 months apart with no evidence of chronicity and with no evidence of obvious cause of pancreatitis. Biliary microlithiasis has been overrated as a cause of idiopathic recurrent pancreatitis. It occurs only in 10 to 15% of the patients as a cause, not as two-thirds cause as it was thought before. To make sure that it is the cause of pancreatitis, deranged LFT is very important. If it is not there, it is unlikely the cause and it is just an innocent bystander. And EUS is the best modality to diagnose microlithiasis with a 96% sensitivity. Pancreas divisum is not an important cause, and SOD is probably highly overrated and does not exist. And as a cause of idiopathic recurrent pancreatitis, it progresses to chronic pancreatitis in almost 50% of the patients. So usually it is an early chronic pancreatitis, which can also be diagnosed by endoscopic ultrasound. Genetic mutations, SPINK1 and CFTR account for 50% of the cases which are left in such cases. In patients who are more than 50 years of age, please rule out an occult malignancy as a cause of pancreatitis, and investigations should be done approximately 8 to 12 weeks after the attack of pancreatitis and include MRCP and endoscopic ultrasound. During recurrent attacks, there is no need of getting repeated CTs, and antibiotics are not needed during such attacks. The second talk was about pancreatic cysts, which was delivered by Dr. Sandeep Laktakia. He started with the word that it is confusing, and it is really confusing. And the cysts can be detected in almost 2.5 to 13.5% people, and they become common with increasing age. And they can be seen in up to almost 40% of the persons who are undergoing MR or MRCP beyond the age of 70 years. Pseudocysts are a common cause. Serous cyst adenomas are the other important cause. They are usually asymptomatic and should be followed almost yearly. They need surgery if they cause compression symptoms. SPEN always needs surgery because this occurs at a young age. The patients can have, for diagnosing IPMN or cystic lesions, MRI and MRCP is the investigation of choice, and 40 to 50% are easily picked up, and one can diagnose whether they are arising from the side branches or from the main duct. And benign versus malignant can also be differentiated in almost 2/3. How to manage these is unclear. However, if they're symptomatic, then EUS can be done as a supplementary investigation. And IPMNs need surgery if they are more than 3 centimeter, if there are mural nodules, if there is a dilated duct associated, and if there is a positive cytology for malignancy, or the patients are having jaundice. If the fluid is aspirated, which may or may not be done, then CEA is an important thing to diagnose that they can be mucinous, and 192 level is taken as cutoff. Cytology is only 1/3 sensitive, and mural nodules and thick wall are more important. Upcoming investigations are cystoscopy and confocal laser endomicroscopy. Other alternatives to surgery are EUS guided treatments by injection of alcohol or paclitaxel, and even RFA of the cysts can be done. The third talk was delivered by none other than Dr. Nageshwar Reddy, which was very clear. His first point was to exclude that the patient has PSC or not, where cholangioscopy and FISH are very important. And dilatation of the stricture is the treatment of choice. Then came whether it can be benign or malignant. For diagnosis of malignant strictures, for the distal strictures, EUS FNA was the modality of choice. because tissue is the issue while diagnosing malignancies. For proximal strictures, one could go for cholangioscopy, especially in indeterminate strictures by CT, MR, or EUS. And cholangioscopy in various studies has shown a sensitivity specificity of more than 85%. In their own study, they have found that it is more than 95% sensitive with an accuracy of almost 88%. Then there was a concept, newly coming concept of extracellular vesicle in the bile, which is almost 100% accurate, and it is done by collection of bile and is done by nanometer. Then the other thing which was brought up was which stent to be used in malignancy. Always it is the SEMS which is better. In proximal strictures, in type 1, 2, and 3B bismuth, unilateral stenting would suffice. While in 3A and 4, it would be the bilateral stenting which would be required. Whenever required, always take the help of interventional radiologists, especially in type 4. And to increase the stent patency, add photodynamic therapy, RFA, or brachytherapy. RFA is very important, and it can increase the patency by almost 3 to 6 months. And as of now, EUS bile drainage is still in a primary stage and should not be taken as the primary modality of treatment. For benign strictures in the proximal, especially due to post cholecystectomy strictures, multiple stents is still the treatment of choice for 12 months. For distal strictures, especially chronic pancreatitis, if not associated with a mass or extensive calcification, covered metal stents for 12 months, removable stents are the treatment of choice at the present. However, multidisciplinary approach is always better. Never shy away from consulting a surgeon or an oncologist. Always take their help. The next topic was by Dr. Vivek Kaul for post-ERCP pancreatitis. According to his talk, ERCP is the most risky procedure, and apart from bleeding, perforation, and infection, which can be managed by different modalities, pancreatitis is the most life-threatening and life-altering complication with an incidence of approximately 3.5%. It can be diagnosed if you have 2 or more of the following: pain after ERCP, more than 3 times rise above the upper limit of normal of lipase or amylase, or CT scan is if suggesting. The risk factors of patient risk factors are: if the patient is less than 60 years, female patient with history of SOD, and with normal extrahepatic or normal CVD size, prior history of pancreatitis, and history of acute pancreatitis in the past. So we have to choose the patients in a proper way, and there should be nothing known as diagnostic ERCP anymore. ERCP should be done with a therapeutic intent always. Then the risk factors otherwise are basically risk difficult cannulation, if we have done a pre-cut, multiple contrast injections, if we have put in fully covered SEMS, and if we have done a endoscopic biliary dilatation without any endoscopic sphincterotomy. So to prevent such incidence of pancreatitis, one can go for guide wire assisted cannulation, prophylactic PD stent, especially if we have done multiple cannulations of multiple contrast injections in the PD. Then rectal indomethacin, which is going to be shortly available in India also, or rectal diclofenac. IV fluids is the most simple thing which we can follow, especially ringer lactate, at a rate of 3 milligram per kg per hour, which can be started prior to the procedure. And somatostatin was another thing which is still under trial. Always anticipate problems, take a proper consent, because otherwise we can face a lot of medical issues. And always define an indication. Never take ERCP lightly. Manage once it has occurred in a proper way, like any other case of acute pancreatitis, with fluids, monitoring, good pain management, incentive spirometry, and other things which we normally do. I don't think we need to summarize the talk of Dr. J. Pasricha because it was all innovative, except that we look forward to stem cell therapy for achalasia cardia, and we should await the glove of the scope tip, that is scope seal, in future. Thank you very much.
Thank you, Mandeep, for giving a very apt summary of what we have learned from today's proceedings. As a tribute to our speakers, moderators, and expert panel members, I'm happy to announce that we have about 3,000 people who are still glued on to their TV, laptop, and the mobile screens to listen to this excellent talk. I do apologize for having overstepped the time because the content of the talk was so good, the discussion was so lively, I didn't want to interrupt the good quality speakers. With that, may I request Dr. Ashish to propose a vote of thanks and invite everybody for tomorrow's session. Dr. Ashish, please.
So on behalf of the organizing committee of clinics in Hepato-Biliary Disease 2020, organized by the Institute of Liver Gastroenterology and Pancreatico-Biliary Sciences of Sir Gangaram Hospital under the aegis of Delhi Liver Foundation, first of all, I would like to thank all the speakers for delivering very lucid lectures covering all the recent advances and summarizing the content in the allotted time. I would like to thank the panelists and moderators for making each session very interactive and very lively. And since no conference is considered successful without the participation of the delegates, we are really thankful to all the delegates who participated, not only from India, but from across the world. And we had close to 3,000 participants, as Dr. Anil Arora said, which is really a huge number, and most of them remained logged in throughout the conference. My special thanks goes to all the international speakers and delegates who participated in spite of this being an odd time in their part of country, their world. And next, I would like to thank the Micro Labs as our academic partner for their logistic support. And last but not least, I would like to thank the event partner, My-Provide, and especially Mr. Pranav Vishwas for providing the excellent platform for this meeting with flawless management. I would like to invite all of you for the fourth day of the meeting, that is tomorrow at 5 p.m. Since it is a long session tomorrow. And the theme for tomorrow's meeting is recent advances in diagnostic and therapeutic endoscopy. With this, I end the session. I hand over to Dr. Anil Arora.
Thank you and good night, everybody. I hope you have a comfortable stay and thank you so much for being a part of our meeting. Look forward to seeing you tomorrow. Tomorrow the session starts at 5 p.m. Thank you and bye-bye.
Thank you. Thank you very much.